Good morning, everyone. It is a pleasure and an honor to be here. Thank you very much to Marco and to Stefano for this invitation. My name is Eva Llopis. I'm musculoskeletal radiologist from Valencia, Spain, and I'm recording from snow in Chicago. I hope you can enjoy the case we have prepared for you. So the case is our second case, and it's a 49-year-old gymnastic enthusiast with acute elbow pain during exercise with biceps curled. The orthopedic evaluation showed flexion deficit, painful active and passive supination, hook chest negative, and passive range of motion were maintained. I'm going to first show you the MR and the different planes that we usually use. So first we're going to scroll through the axial proton density fat set, and you're going to notice there are some areas with soft tissue edema, some fluid effusion that surrounds the elbow structures, and there is some entities that have increased signal intensity. This, as I said to you, this is the T1 proton density fat set. Let's go to the T1 weighted images. We always do T1 weighted images, T2 weighted images, and we scroll up and down to see all the disease. This is our standard protocol from the elbow, and we also do a coronal proton density fat set to show all the structures. And a sagittal plane. As you can see, there is a little bit of motion. The patient had a little bit of pain, and that this is why sometimes the images are a little bit blurry. So we see that most of the lesions are located into the anterior. So our first task is to mark the distal brachialis tendon. And as you can see here, next to the biceps tendon is the distal brachialis tendon that's going to insert not in the radial tuberosity but in the ulnar. We'll continue with our second question or task, which is the main finding: bicipitoradial bursitis, tear of the brachialis tendon, tear of the biceps tendon, or tear of the myotendinous junction of the biceps tendon. And again, as you can see, and we mark it before, the brachialis tendon is completely normal, but there is something on the biceps tendon. It is surrounded by a little bit fluid, but when we get into the insertion, we see that there is a rupture. Our last task is to show where is the lacertus fibrosus and how is the lacertus fibrosus. Is it intact or is it broken? This is important because in this case, despite we have a little bit of fluid, we see very nicely that the lacertus fibrosus is surrounding very nicely the structures, and we see it like a clear line despite of the edema. So the lathyrtus fibrosus is intact. In this case, and always when you have the possibility, you have to try to do an additional position if you are not completely sure of the extension of the tears. And in this case, you see it very nicely. In this is not actually a flexion and abduction and supination, but the patient could not do it very well. So we profit that the flexion of the elbow, where he was very, that was the best way of him to be comfortable. And we see very nicely the two bundles of the biceps tendon that are separate, and one of them is normal, completely normal, and whereas the other one is completely broken. So in this case, we have an isolated tear of the short head of the biceps tendon. You can also see when we go more proximately how the biceps tendon, the two heads of the biceps tendon, they curl and they do twist when they go into the forearm. Here on the T1 weighted images, you also see it a little bit very nice. You see the long head is inserted normally in the proximal side, and the short head is completely ruptured without disruption, and this is thanks to the lathyrtus fibrosus. Again, on this oblique sagittal image, you're going to see very nicely the two bundles of the how they separate the two heads of the biceps tendon, the long head that inserts superior and the short head that inserts inferiorly, and how they merge and they do this twist when they go into the insertion. So remember the anatomy of the biceps tendon, that we thought that we had only two different, short and long, on the proximal, on the origin in the shoulder, but no, we also have two different ones, the long and the short one. And remember that when they go up proximal, they twist. So we have two different facets that are completely distinct, and they can be very much depicted on MRI, even if you don't have a wonderful MRI. You have to be careful. Always remember to include in the axial planes the full radial tuberosity to avoid missing some of the parts of the biceps tendon insertion. This is important because as long as we are improving with our diagnosis skills, the surgeons are also improving and they are getting better on how to treat. So these isolated injuries of the complete injuries, as in our case of the short head of the biceps tendon on its distal insertion, they do a special surgery that has much better prognosis than if we have a complete tear where they do have to have a more complex, with more complication, heterotopy calcification, risk of ruptures. So remember, the solution is that the lathyrtus fibrosus is intact. You see that there is a full thickness tear of the short head of the biceps tendon that's dotted in this cycle, and the long head of the biceps is completely normally inserted. So the final diagnosis is the full thickness tear of the biceps tendon of the short head of the biceps. Injuries of the biceps tendon are common in the middle-aged men, caused by excessive extension during the active flexion. There is always, in these cases, there is a little bit of a fatigue component. The distal tendon is composed by the short head and the long head, which has been seen in distinct bundles. They say up to 20 to 25, but I will say that more and more we are able to see it in much more patients. The short head of the biceps tendon inserts more distally and anterior compared to the long head, and its function is the flexion, whereas in the long head is the supination. Incomplete ruptures of the distal tendon of the biceps tendon more often involve the short head and have better prognosis. It is very important always to depict how is the intact lathyrus fibrosis, because it retracts the retraction, and then if it has a lot of retraction, you will have a much more complicated surgery, probably involving both bundles. And with this, I like to thank you for your attention, and I hope I could do this video properly. Thank you very much.